Okay, Valeria, are you ready to go?
Yes.
Okay, so I think we can start with the recording and accepting. Video on, global governance students, please. Video on. So good morning to you all. It's a great pleasure for me to inaugurate this third event of our Global Governance online lecture series, Lessons and Challenges on Innovation Learned from the Israeli Experience. We have, as I said, our third guest, Assaf Parker, whom I will introduce very soon. And before that, we have the honor to have a welcome from Ambassador Raphael Singer, who's today Minister for Economic and Scientific Affairs at the Israeli Embassy in Rome, and from 2006 to 18 was Ambassador to Peru. As usual, as it's customary, I'm going to introduce now our guest, but keep in mind there's going to be an important Q&A session after his speech, where you are all welcome to contribute. So let me briefly introduce our guest, thanking him so much profusely for being with us today. Assaf Parker is head of digital health technology at the Israeli Ministry of Health. Before joining the ministry, he used to work in the private sector, mainly in the field of management operation, customer relations, economics. He holds a Bachelor of Arts in Economics and Business Administration from Ben-Gurion University and a Bachelor of Science in Industrial Engineering and Management from Afeka College. As I said, he now heads the Digital Health Technology Department with the Israeli Ministry of Health, where he leads multiple digital health initiatives, many of which he will talk about today, from concept design to implementation, sort of dedicated to find, he will tell you, in new, innovative, cutting-edge digital health solutions for various national and organizational challenges. He has a team he will talk about where they design solution, enabling technological integration directed at improving digital transformation, taking care also of what emerges from local and international industries. The goal, he will tell you, I think, is to empower patients and health organizations to provide healthcare to all. Minister, Ambassador, I leave you the floor to address our global governance students and also the students of Tor Vergata University that have joined from other programs and are following right now together with other people on our Facebook Live event. Ambassador.
Good morning, Professor Piga. Thank you very much for this opportunity. Thank you for all the students joining us this morning. Before I give the virtual floor to Assaf to talk about digital medicine, we thought in the embassy it would be interesting in briefly in 2-3 minutes that I could talk about a little bit what we do in the Israeli embassy in the section of promoting trade and connections between the two countries, between the public sectors and the private sectors. Because today, in this day and age, one could ask himself, why do we need a trade officer at all? The information is out there. Everyone knows what everyone else is doing. And that's, I think, and I'll try and explain this a bit in a nutshell. Obviously, between Italy and Israel, there's been relations even before the beginning of the state. Fiat, for example, a great Italian manufacturer, has been present in Israel since 1946. So Fiat doesn't need to be introduced to the Israeli public or to the Israeli private sector. The same thing, I'm sure some of you, when you go to the supermarket, you see avocado that says Israele. Of course, the Israeli agriculture, traditional agriculture, doesn't need to be introduced to the Italian public. Our job is to find the added value, the things that are not that obvious, and try to connect between the great Italian industries and the Israeli ecosystem, the Israeli startups, the Israeli innovation sector. And we are active in a lot of sectors. I'll put medicine aside because Assaf will talk about it, but in very brief, I think it'll be surprising for the public to know in how many things we are active. Take, for example, the space sector, something way above expectations. You know, we're in another galaxy. Yes, Italy and Israel have amazing cooperation in the space. Now orbiting, there is a satellite, Israeli nano satellite, that was launched on an Italian launcher that is doing now experiments in experiments of liquid materials in a situation without gravity. Really breathtaking technologies that were basically Israel and Italy technologies put together. In the issues of mobility, Israel doesn't make one car in Israel. We don't make one car in Israel, but we have hundreds and hundreds of high startups and small companies dealing with the automotive sector, with the mobility sector. I'm sure most of you might use Waze in your car, but it's way above the Waze that was developed in Israel. For example, we're working in Italy on the issue of developing light batteries for electric cars, for example. In the area of energy, Israel was never a big energy player. We never had oil. Now we have gas. So we were never really in the focus of the big Italian companies of like Eni or Snam or Enel, but that's changed. We have agreement between Snam and an Israeli company that is developing ways to manufacture hydrogen gas using solar energy. Basically, not using a fossil energy to create hydrogen gas. That's totally green energy section. Enel has now 3 hubs of innovation in Israel. One dealing with energy hub, cyber hub, and also now a fintech hub together. Enel with Israeli companies working in innovation on those sectors. Same thing with agriculture. Everyone knows the traditional agriculture, but now we're talking about smart agriculture. Also, we're working on that issue. And of course, the issue of cyber. Israel, for many reasons that you probably understand, has developed unique capabilities in the area of cyber. And we're trying to show how these cyber that maybe traditionally were developed for more military use can be used now in the private sector with fintech, of course, and things like that. So that was in a very brief what we do in the embassy. Our colleagues, the Italian diplomats in Tel Aviv, are doing an excellent job also in bringing Italy to Israel, and we're trying to bring a bit of Israel to Italy. So that's basically what we do in a nutshell, and I'll keep it short, so let Assaf carry on. Thank you very much.
Thank you. Assaf, please, the floor. Assaf, you are mute, so we cannot hear you.
So I said before that first of all, it is a real honor to be here. Thanks, Mr. Zinger, for the beginning, and thank you, Professor Piga, for the opportunity. In this lecture, I would like to represent our key elements of promoting and enhancing telemedicine in Israel, and a few of our broad national digital health strategy. The presentation will be a really very strategic way to promote those things, and the way from making a strategy to implementation at our health organizations. So why we're here and why we're doing telemedicine, why we're doing digital health, why we need to make digital health. So first of all, we all over the world chasing the same problems and trying to find solutions for our main issues in our healthcare system. We've got aging population. It's grew rapidly all over the world. The life expectancy, and if you're talking together with the aging processes, and you put one more things like how the fact that we are now at the era of abundance of sugary food, and And so we see now all over the world, especially in Israel, increase in chronic disease, even at young people, not only elderly people. The drugs and the medical technological becoming more expensive, and it's affect the healthcare system. And patients need and deserve for good healthcare services, and they want to get it in several channels. The traditional channels, by going to the clinic and visiting the doctor in the clinic, it's one of the channels that we use to get our services, our clinical services, but I think that it's not enough for all the patients. They see other industries, the banking industry, and more, and they can see that they can do things from distance and do it efficiency. And when we're looking at those challenges, global challenges, we now, or before, understand that if healthcare system will keep working like they're working today, the same way, we won't be able to provide the same services, because the demand for health services is getting much more faster than the people that becoming doctors and nurses and other professionals. And by the regular way of thinking that we build more beds and more hospitals and bring more doctors and nurses, it won't be enough to catch those really grow of demands. And we think that the digital solution combining with the innovative solution is one of the success key factors for finding solution for the problems that we saw before. And one thing I must say, that we all know that the digital solution it's can't work by itself. Because of this, we look at innovation solution. We've got both innovative and technological strategy, because the change that we want to be, and it started a few years ago, it's combined with many aspects. It's not the technological aspect by itself. It's many various and multiple interdisciplinaries, people that acting in the fields, and multidisciplinary targets. And we know when we want to achieve our goals, that we need to find a balance between things we're doing, and we will talk about it more in the slides. When you look at our strategy, let's look at the bottom of the slide. So first of one of the things that one of the ways to look at our target is to get a better use of our data in our healthcare system. So first, there is all over the Israeli organization, if it's hospitals and if it's HMOs. HMOs, it's the health organizations that are like insurance company, but it's more a non-profit organization. There are 4 HMOs in Israel that covering all over our Israeli population, and delivering the clinical needs for the patients. And sometimes where there are some skills that they've got, like surgery and like a specialist, and someone they need something urgent to do, go to the hospital. But most of the services are given in Israel by the HMOs. We've got 4 HMOs in Israel and about 35 general hospitals. And all over Israel, the hospitals and the HMOs got electronic medical records that store the data, the clinical data of the patients, about the 20 years of data. And the data is the clinical data is the new gold, say it. We can take those data and carry out research on data, big data research, other analytic tools to see the opportunities of using this clinical data. And after we make those rituals, we can achieve better care at the primary use, using to look at it different way. There is a secondary use, is the way to use the data for research, and the primary use is the way to use the data for treatment, for clinical needs. The second target of our strategy is the new models of care. In order to make a change, you need to change the way that the healthcare system works in several ways. And if we will make more models of care, not only the regular models of me going to the doctor in his clinic and coming back home, we won't be able to achieve our goals. And the models can combine monitoring of people with the treating from long distance, digital processes that the HMOs and hospitals have and keep designing. We need more collaboration. Sometimes when you find the advantage of the organization and you combine it with the advantage of other organization, you can achieve a lot of more. And as we know, it's a transformation, it's a digital transformation area. And in digital transformation, there are many new skills and professionals that enter into this area. At the clinical aspect, not only the system aspect, the transformation is to start and to work more with people, with patients when they're healthy, and less to treat patients when they're sick. And this we can do by preventive programs and predictive decision support systems, and by personalize the way that we treating the patient. And we must be, our target is to be, must be proactive with our patients. Two last things about our strategy is, first, that human-centered care is not a slogan, it's really approach in order to empower the patient for treating by himself, but not only by his doctor. And the second one is the need that our healthcare system and healthcare solution will be sustainable. Because it's very nice, there are new technologies and a new solution, but it's not enough. We must see that the technologies are economic, cost effective enough. When we look about the way to achieve this strategy, we're doing a few verticals. First is the policy vertical, policy to clarify the way to make research with data. We need incentives for the healthcare system in order to help them to work with the risk of using new things, and building local and global healthcare system infrastructures. And when we want to achieve our target, we must find a balance between facing current challenges and try to fix things that doesn't work now, and investing and developing new ways from the long run. I have some examples of things that we're doing right now at the field of our current challenges. At the policy side, we are clarifying the healthcare system, how to use the clouds with all the sensitive clinical data. You all must know that clinical data is very sensitive. We need to keep the patient's privacy, and there are some things that you don't want that someone from outside the appointment or the way of treatment between the patient and the doctor will look at this data, and especially not with the cyber attacks and things like that. So it's very important to first to enhance things, to work faster, to use technology, but still we need to be sure that we're doing this in a good way. So one of the ways to clarify the way to work with the cloud, with all the sensitivity of uploading clinical data to the cloud. Telemedicine policy helps another thing to clarify the way to ensure that health organization taking the right steps into telemedicine. There was the first circular in Israel in about 2012, and the second circular at 2019, in order to help them to build their own the HMOs and the hospitals on new services of telemedicine. And the last one was in 2019 was to ensure that there is the reimbursement is fine. And second of all, when we're looking at other industries, to be sure that we won't close clinics after we open telemedicine services, because there are many people that still need to come to the clinics and prefer to take those meetings with the doctor face to face and not via the technology. And the second thing is with incentives. We have here in Israel pilot program. Is a program for collaborating startups and hospitals and HMOs. The hospitals, the health organization is kind of subcontractor of the startup. The startup collaborate with him in order to make some pilots, some clinical research. And by this collaboration, we can see that every side of the of those two kind of companies, the health company and the industrial company, the collaboration between them is very good for their achievement, their goals. The startup get his own partner, clinical partner. It's very important for this industry to work with clinical partners, and hospitals and HMOs can achieve a solution in their own house. And we have a challenge tenders. Challenge tender is our way to see if there are companies that can help the Israeli healthcare system find a solution. For example, I made some tender in the field of fall preventions, elderly fall preventions, and I got a great solution. And that one of them is supposed to finish right now a pilot in one HMO, and achievement are very high in the side of preventing falls from elderly people. And other solution checking now at another HMO. So it's was effective way to find solution together with our ecosystem, with our startups. And there is one more thing that we started doing in 1.5 years ago, is an incentive program for health organization, in order that they build their own solutions for their own needs. These things make them becoming, I say it, managed startup, because it's a startup action activity that's happening in the health organization, and it's managed because the clinical people acting in this field and helping this field build in the right way. The infrastructure that we're promoting is the EITAN. EITAN is Health Information Exchange Network in Israel. It connects all the hospitals and all the HMOs. It's a peer-to-peer network for the ones that know better these technologies. It means there isn't one lake of data. It's separate, decentralized. And for me, when I come into the hospital, I can the doctor can see my clinical data that is stored at HMOs. It's of course not all the data, is part of the data, but it's several things that's very acute for someone who visit the ER or other section at the hospital. And when we're looking ahead, there are a few, again, the verticals of policy, incentive, and infrastructures. There is few things that we are doing. First, a policy for carry out secondary use of data regulations. Again, even when we acting with only with data and not with treatment, we must be sure that there are the committees of ethical committees that will approve those clinical research. And it's very important to clarify the organization, what is the boundaries between the right and the unright. We call it enabling regulation because our point of view is to help things happen and not stop them from happening. We launched a few months ago a paper with digital health technology assessment in order to help organizations to assess new technologies, new companies that are coming and want collaboration with them to look how they achieve the targets from the collaboration with the startups. And we want to start this year working on real world evidence way of view, maybe to help applications, health applications enter faster, and after this to see the effect of this application on our population health. And in the incentive way, we had the incentive program for all the health organization in order to hire human resource and build infrastructure, the fields of clinical data research. FHIR is fast health interoperability way to connect and integrate between solutions, and we're working on this too. We had a big data platform in Israel, their name is Timna, in order to help especially small organizations to make a big data platform. And we are working now on more accurate data in our healthcare system by combining and using ICD-10, ICD-11, it's coding, it's clinical coding, and Snowman in Israel. This thing, we are planning a way how to achieve our goals in Israel. Just a little look on the digital health ecosystem here in Israel. So we are proud that we've got ecosystem for promoting innovation in the digital health. We have many startups that are acting at the field of in developing the field of digital health. We have a great data in Israel, more than 25 years of data, clinical data that's stored at the health organizations, health EMRs, the clinical systems. We got four main players. They are the HMOs, the non-profit insurance companies that serving the entire population. In this, it's quite centralized. in one end, but in the second, in other end, where the HMOs have a huge data on their patients, and they can really achieve a fast solution for them because they are got many patients. We got hubs and incubators and innovation centers inside the hospitals, inside the HMOs that help them to make digital health. And the government by itself put their own effort every year in order to support both the industry, but not only the health organization in order to build new solution for the healthcare system. So after I spoke a little bit about our digital health strategy, let's dive a little bit into this telemedicine revolution that I think we all over the world feeling right now. When we talking about telemedicine, I used to separate it to two main things. First is telemedicine that we all know. It's clinical appointment, but instead of do it in the clinic, we can do it by phone or by video. Most of the telemedicine all over the world that's happening, it's this kind of telemedicine, especially at the COVID era, when people avoid from going to clinics and prefer to try to get their own services by phone or video. Most of those services are by phone. It's less complicated and more easier for the patients. And when we started acting at this field and understanding, a deep understanding of this field, we saw that to make a clinical appointment by phone, it's not like make a clinical appointment by phone. It's very different way, and there are a lot of limitations with the way of taking good care of our patients in Israel. The second kind of telemedicine, and is very interesting kind, is the way to change the production function of our healthcare services and designing new models of care. For example, if regularly I'm going to the doctor for some problems, so maybe there is things that are happening now, I can chat with him and make the appointment by chat. There are many problems that I can get a solution from my doctor by chat. A few days ago, I need to do some medicine for coughing, and I wrote to the doctor, and I get a really fast prescription. And it doesn't mean I need to check my liver and touch my heart in order to give me a good care. And by those new models, we must first ensure that we are improving the treatments. We're not going back. And another side is to building it in a cost-effective way. If we remember the first of or second, remember the first or the second slide of this lecture, we talk about our challenges in the healthcare system, the aging population, and the demand for better and higher quality services. We must see that we're giving those services in more efficient way. And when you're looking at our way to empower the healthcare system, because we look at our healthcare system from the bird eye of view, let's say it like this, we can see and react in a few verticals, the policy, infrastructure, and incentives, like I spoke before. but in especially telemedicine, the learning is very, very important in order to make a good telemedicine, because there is many different and many areas of specialism in medicine. So every specialist in every area got his own sensitive way to treat patients and sensitive way to start working with patients in order to prevent problems. So as we understand it, the learning issue is very important for our way to achieve our targets. And our objective, our main objective of telemedicine of the age of COVID-19 is both improve the patient and the system. And when we're looking at the patients, so we want to avoid deterioration, hospitalization, especially at risk population. We can achieve it. Can we really do it? Increase the patient choice to empower themselves. We must understand that if we increase the power of our patients, the treatment will be supposed to be better because he's going to be involved more and more in his way to treat, and he will take his medicine in time when the doctor tell him, and not and get neglected. And one more target is to empower the doctors, the nurse, and other health professionals by building more efficient and integrated tools for the providers. We know that in one end, information systems are very, very good for healthcare system, but in other end, it's called the burnout. Is the doctors really get disturbed by these technologies? When we're looking at when going to clinic and looking at the doctor by work on the information system, his health information system, we can see that it's not easy for this to go, first to use those systems, second to use all the data that we as a patients get from Google and try to explain us what this data that we got from Google is wrong from this for this issue. So we can see that all the data change, all the digital change can be effect on the burnout of the doctor, and we want to easiest tools for him to get the right decision, to get the right data in the right time when he's supposed to make his decision. We want more preventive and personalized health. And we want to keep up that the patient will take up their rights of using medical services. And the side of the system improvement, so it's very important to look at the outcome. When we're doing something, we make sure that we're achieving what we want to do and not waste time and money on things that are not good enough and not efficient enough and not cost effective enough. It's other important way to achieve good services for the long term. To increase the access of more patients for the telemedicine services, because it's very important to help them with new channels of services. When we look at this year, the year the 2020 that we saw, first with all the COVID-19 problems, we can say that this is the year of telemedicine. We saw many health organizations. I think most of them act very fast to find a solution for appointments with the patient in order to help them in time. and they open new channels of way to treat those patients. And this is one side. So we can say we get good numbers with in our wave. For example, in our first wave of COVID in Israel, we can see a large increase in GP video calls in the HMOs. A lot of appointments that happening online, and even we saw a lot of an increase among 60 plus patients that they are entering this area of telemedicine with great skills. I'm not sure that enough skills. For example, the talk about a little bit about our Corona activities at the beginning of the Corona. When we start this the Corona issue, it's at the beginning, it looks like a war, a global war that we must act in this war and try to find solutions. Some of them we succeed, some of them we didn't succeed so much. So I tell you, for example, about three startups that we work with. The first is Datos, that we collaborate between the startup and HMOs in order to monitor the COVID-19 patient at home with a questionnaire, daily questionnaire about their symptoms. And the second was with Belong, that help us build information and support people that asking questions about the quarantine and these kind of things. And one more is diagnostic robotics that helped us deliver 1 minute symptom survey in order to see whether we can chase those COVID-19 pandemic. I think that with most of them we succeed with our work. We find another barriers when we work with them. For example, on the 1 minute symptom survey, we find out that the patients, the Israeli society is not so much easy attending to answer those surveys. It depends of the way that if you're sick enough or not, if you're healthy, usually you're not answering those surveys. The data monitoring works good because it's aiming the people that had COVID and staying at home. When we look at our system, we can see two main things. First of all, we can see the preparedness. Our health system entered this COVID area prepared. It was a fast solution for telemedicine, and the health organization responds very, very fast by finding the way to treat their patients. In other hand, we can see now, and we saw a few months ago, the complexity and a lot of questions regarding to the quality of medical care. Because and the doctors, when they're giving patients a treatment, asking themselves it's good enough for the patients. And some of them even said that it's really affect the way that they supposed to practice at their medical schools, because it's really new way to give services. And I want to explain a little bit why it's so why it's not so easy to design new telemedicine services. So first of all, there is a variance in clinical fields. There's a lot of clinical fields and a lot of professionals that acting in those fields, and it's not a one size fit all. Every specialist is supposed to check the whole treatment and environment in his meeting or in building new model. And it's very, we try to learn from each other, but every service is supposed to design by itself. The patients are different, of course. There are special needs. There are not one kind of patients. There are different population groups. As we said before, we need to find the economic models. It's not enough that we put our effort with more money on new technology that affect very low on the efficiency. So we must do it right with in economic way of thinking. The regulation policies is always there, especially when we act with clinical issues. There is a lot of knowledge and skills at the side of the patients and same at the side of the caregivers. We need to ask when we're building a new telemedicine service, when to use it, why to use it, for who it's supposed to work and for what new cases it doesn't work. Some of the where the patient supposed to be in this service. It's a right that the patients call his GP doctor from his car and ask him for medicine. If we need to put some boundaries that will respect the doctor. And with all this, we cover the technological issue that's supposed to fit and solve problems and not to try to find its own usages. And we decide to learn. First, learning from one of the ways to learn is to ask people that giving and receiving a telemedicine service about their experience. So we ask the population, we ask the doctors, we ask the nurses, we ask the other professionals. And second thing that we wanted to do is, and this is one of our main minorities, is to see that all kind of population inside this not get neglected, and to ensure that nobody left behind. So we carry out one research in Israel in order to understand better the needs of one of our population. And it helps us very much to deliver this knowledge to the health organization. Second thing we do in order to make more learning, collaborating, and to work together in our system is to build the Israel telemedicine community that working together. We have more than 600 professionals, 10 working groups in the telemedicine community, a technology group, oncology group, then a GP group, a nutrition, genetic, rehabilitation, many groups that leads by the healthcare professionals. We made this collaboration with together with two organizations that helping with leadership in Israeli healthcare system. They called Maoz and Inbar. They both organizations helps us to work with the professionals, with the healthcare professionals, in order to build the leaderships in these sides of the telemedicine. It's very important in order to do things in a good way. What we hear from the community is that what happened in the first wave, for example, that a lot of professionals felt like the country took a decision to make more telemedicine, and the HMOs make a decision, and there was no other option because people didn't go to the clinics in the first way. They needed to get their own treatment from long distance. But the professionals feel that something is unstable with the way of treat, and it is very important for them to discuss with each other a professional discussion and cross-section discussion in order to know better what to do in those telemedicine meetings. At the learning side, so they learn from a different kind of models. They're hearing the pediatric models and oncology models and genetic models in order to see if it's good for their own professional. work, collaborating. It's kind of cross-organization meetings. There's not separation between organizations. In the nutrition group, for example, there are people from all over the HMOs, or people from hospitals, and really planning together the way to do medicine. And they're working together. Some of them decide to really start to write guidelines for telemedicine services. Some others working on other barrier analysis and how to focus on achieving a solution for those the barriers that they've got in the field of telemedicine. Other thing that we've done in this field is to bring incentives to our healthcare system, and we're giving a variety of opportunities for the health organization in order that they will solve in their own way the problems that they see that they've got with new kind of models. We launch an incentive program to the HMOs, to health insurance organization in Israel, in order to make more proactive detection and treatment for at-risk population, elderly people, or other at-risk population, ways to communicate with elderly people at home with technologies that it's more easy for the elderly people to connect with. Decision support systems that help them prioritize flu vaccines, and now it's used for even for the COVID-19 vaccines, the priority tools that they built, tools for remote monitoring, equipment for home care teams. Still, we need for kind of population to go to their home and treatment at home, especially it's elderly population. Tools to help to reduce the digital gaps that happen in prevention of deterioration, home hospitalization area too, and more options. And every HMOs work on their own plan. They choose their own field that they want to and all things that they want to do right now, and they act in with this very well. Other financial incentive program we made for the hospitals to help them build a better telemedicine infrastructures in order to treat new kind of models of treatment, telemedicine heart rehabilitation, some models for preventing hospitalization, second hospitalization in the hospital, digital prescription for the patients that go to the hospitals, and other outpatient services. And I will, in the 2 minutes that we've got, I will try to summarize that the way that we are acting in this field of innovation. We acted when the Corona happened, and after this, it's quite similar for many things that we are doing. So first, when we looking at one problem, a big issue that we are facing with, we need to act. We need to act fast. We need to act immediately in order to prepare our healthcare system with, especially here with the next pandemic waves, and when we saw the flu season that right now we don't have too much flu in Israel, not all over the world, but we at the beginning we thought that if we take this COVID issue and the flu, it will be a really problem for our health system. And after the action, fast action, we're learning, because we must learn by research, by understanding how current models are working. learning from the healthcare system mistake, because when you acting fast, it's definitely that you will make mistakes, and the question is how acute are those mistakes. So we must learn. After the learning issue, there is a transformation for the current models for a new models of care, and adapt those changes in the models in order to build them better. And after the adjustment process, we must act fast in order to check and fix our problems. And I must say it's a never-ending story of innovation, because we're creating after creating, and it's a never-ending process. And that's it. Thank you very much.
Thank you so much, Assaf. Thank you for this very enlightening presentation. Lots of trade-offs, ethical dilemmas, cost trade-offs, issues that I'm sure will want to be explored and give to policymakers a lot of food for thought, especially in these times. So now we typically have a phase of questions and answers. And so I'm going to leave the floor to the students if there are any questions. Let me check. We usually have the blue hand. I'm sorry, I'm not there. Okay, so students, are there any questions here? Shinichi, go ahead. Obviously, introduce yourself.
Okay, so thank you for your presentation. My name is Shinichi Mizuno. I'm from Japan, and I'm a first year student of global governance. So thank you for your presentation again. So as you said, like in the first part of the presentation, Israel is facing aging society, and then so the medical issue will be raised due to the aging society, and then of course, like telemedicine helps doctors to give the more best possible solutions to the patients, and then it would be possible for many patients to receive the better medical services. So my question is is a general one. Like, I'm curious about what do the doctors think about the medicine, because for me it seems like telemedicine can partly take away the doctor's jobs because of this introducing the new technology. So like overall, what the doctors think about this, the new introduction of the telemedicine. So this is my question. Thank you.
Thank you. First of all, it's a disruption. It's not a. It's like every industries that look at when you see for example, in the industry of taxis, when you see Uber and you see Get Taxi, it's disruption of the industry. And in a lot of way of thinking, the telemedicine is kind of a disruption for a healthcare system. And the question is how you do it, and if you doing this in a way that enabling doctors to be in the safe side, to feel on the safe side, to feel that they're doing good for the patients, to feel that they are professional in their work, it's easier to do this. Still, there were a lot of people that was against telemedicine before the COVID, and there's a lot of people that are against doctors against telemedicine right now. But I definitely see the change. I can see that a lot of doctors that was against it saying now that they understand that it's something that happened and they can't avoid this. Because if you look at the patients want and deserve their needs and want to get these services, part of them. by telemedicine, there is no other options for doctors, and the doctors now trying to find a way to do it in a efficient and good way, because they really want to be sure that they acting good and giving the great treatment like they gave at the clinic. It's not easy. It's really not easy, not for them and not for healthcare system. But it's something that happening. It's what we must do to ensure that we as a country doing is as right as we can.
We have a chat. We have a chat question by Luigi De Angelis. I don't know if it's Luigi De Angelis or not, but the name is Luigi De Angelis. What is the role of artificial intelligence? Do you already have algorithms implemented in the workflow of clinical data analysis?
Yes, there are many algorithms that some of them came from the startups in Israel, and some of them came from the HMOs and hospital by themselves. Some of them are FDA approved, like the imaging algorithms, in order to see if someone's going, for example, to hospitals and got the image of his body and heart, and there is an algorithm that is supposed to check if there are someone that the doctors at the hospital they didn't see. This is one kind of algorithm. Other kind of algorithm is to see people that coming to the hospitals, and trying. We have a pilot on this, and to see who is in other in what is it, in more worse activity in the hospital, and other algorithms in the field of prioritize clinical treatments, to find the way algorithm to find the way to the right people get injected, got vaccinated faster than others. There was algorithm in the field of cross problems in the people life. If you combining the treatment and you combining the age and combining the several chronic disease, you can see what kind of population you need to be more proactive with him. We can see that more and more AI entering to the healthcare system, and this is one main issue. The second, we must understand that there is DSS, decision support systems, at the field of problems with contra indications with medicine, but we can see that there is a lot of issues that when we're talking about AI that happening when we doing this. For example, if there is one algorithm now, and after there was a clinical research to see if this algorithm is working good, and after this there will be an implementation at the hospitals. So we get the algorithm and we check it, and it's good, and we work with them, and it helps to treat patients. But what's happening if the algorithm is learning by itself? Because it's some of them are self-learning algorithms, and the whole way of treat is changing. So you must do another research, you must carry out another clinical research in order to check if the new algorithm is good or not good. There's a lot of ethical issues and regulation issues. We need to make sure that we're doing this board. There are several things that there are decision support, and there are several things that are really in the side of a decision, and there's a different sensitivity to act with those technologies. But definitely the AI is here.
It's very interesting. Francesca Vierzi.
Good morning. I'm Francesca. I'm from the third year of Global Governance. So first of all, thank you very much for your inspiring presentation. I just want to ask you your personal opinion about the future picture that society will have of doctors, because from this COVID pandemic period, for example, we are living in a very difficult era, in particular for our society, for our daily actions and routines. And I just wanted to know if this new technology and this online assistance from doctors will change our picture of doctors in the future, because hopefully we will go through COVID-19 and this pandemic will finish one day. So what is your personal opinion about it? And I don't know, and the second part of the question is, I don't know if you know that in Italy, at the very beginning of the COVID-19 pandemic, governments have developed a new app. It's called Immuni, and we use it in order to track new cases of COVID-19, and you can receive assistance and all the advices that you and all the actions that you can do to prevent yourself and the others. I don't know if it is there is a similar thing in Israel, or have you ever experienced something like that? So a tracking app that can help government. Thank you very much.
One question, thank you, Francesca. One question is, what you meaning by you saying the doctor picture of the future?
Yes, because the personality of the doctor, like because you can receive assistance online, and it is like breaking down the traditional picture of the doctor that we can see, or the assistant that we can receive from hospitals, for example, because it's the new way of communicating with the patient. So in this way,
a new way of communication with the patients, definitely right. It's a new way of getting your clinical data. We have a discussion at for example, at the telemedicine community with the geriatric, that there are several questionnaires to elderly people. But if we keep those questionnaires for elderly people and bring the GP doctor the data that it needs to, in order to find the right moment to talk with his patients and tell him that he's supposed to go to geriatric doctor, it's very important to achieve a fast solution for elderly people. For example, this is the field of so there's a lot of potential in this side. It's really changing the way that doctors work. And I think that more and more skills will need to be entered to our healthcare system in order that it be more efficient. But still, we need to remember that medicine is medicine. It's there is some boundaries and some activities, new activities to do. But the doctors are high professional. They know how they know better than everyone how to make the treatment right, and they will face it very, very good. With for the second question of you about the tools for the population, we tried two kinds of tools in Israel. First was voluntary tools, in order that people will download some app. It's called in Israel Amagen. It's the Defender, if I translate it to English. And we saw when it's a voluntary action, not many people downloading this app, and doesn't want that someone will tell them that they meet other one that have COVID, and it's really hard to work with high numbers of population in order to detect the meeting between them. I'm not sure if it's right and if it's good enough, but we in Israel used a tool, a security tool, in order to try to find those meetings between healthy people to COVID people, and to ask them to tell them to go to quarantine. But this is very important in one hand to close this distance, the social problem, and in other end, it's issue. It's an ethical issue that we need to be sure that to act well with this issue.
Other questions? While people think about this, Assaf, I saw a slide where you were mentioning dilemmas with the Arab population, but then I did not understand fully what you meant by that. Could you go into it a little bit?
Yes, I will speak about this. We want to be sure that when the telemedicine revolution is happening, the society is not left behind, and we try to understand in what kind of fields in let's say it like this in long distance services if the population looking at their HMOs, they know they right for services if the language, the Hebrew language, that most of the services, the barriers. So I think it was very important to us to deep understand the barrier of making a telemedicine solution. We found interesting things. We found that in Israel there are not so many differences between the Arab solution and other population with the way to use tools, digital tools. In other end, there is something that it's more traditional to meet the doctor at his clinic. And right now, what we are focusing on is first working with the HMOs and the programs that they will bring more and more information, not only Arabs, it's elderly people, it's religious people, it's people with a different kind of approach, and we really try to push the HMOs to build solution for special needs. One of the HMO, one big HMO in Israel, decided to work on this, in order to show the opportunities of giving healthcare services and healthcare rights in the HMOs. It's not enough to translate. It's a more deeper solution you need. If you want that your app will be in several languages, not only Hebrew, you need to build it from the bottom in order that will support several languages. And if it's not building from the bottom like this, it's very hard to make changes and to show several languages solutions. So we help organizations to build their own ways to deliver as much as they can information for all over all kind of populations. Solution from elderly people, solution from religious people that not prefer not be connected to the network. And in this thing, we must be one of our way to act, because as a government, we want to be sure that there is some market barriers that are not helping us to promote it in a good way. We need everybody get the right for medicine.
Thank you so much. I don't know if there are questions from the students or on the chat. I wanted to ask you also the following. If we were to transfer all this huge technology to another country that lacks the institutions, or that wonders whether the simple transfer of technology is going to be enough to make a jump, or I guess this is also a question related to what kind of interdisciplinary skills are needed to make all this work in an effective way. Would you say it is a failure to begin with, just to simply transfer the technology in the health sector and expect results? And what is the complementary social and human and physical capital that is needed to make it, for example, in a poorer country, work as effectively as it has done apparently for you?
First of all, every change we're doing, it's human change. It's technology. Okay, the result of startup will bring us solutions. A lot of companies that they know how to make IT and how to act with technology, but the real problem is to work with people. This is and that's why I think it's so important to build skills for managing skills for acting together and collaborating together and hearing several kinds of ideas. When you're talking about kind of a revolution, you need to hear the doctor and a little bit understand what the doctor said, and you need to hear the IT people, the technological people, a little bit understand why he's saying, and in the end, and you need to hear the patients and to say what is his pains. So I think that the multidisciplinary approach is very important to make the right decision. And when we're building infrastructures for healthcare systems, designing things maybe from the beginning or maybe from taking infrastructure and approve them, we must see that we're doing something that's going to work. It's not enough to, and we have experience with solutions that we thought that they are good for all the healthcare system, and they wasn't good for all the healthcare system. For example, a few years ago, in the Ministry of Health, we decided to build the infrastructure for telemedicine and to deliver the infrastructure for the healthcare organization. But the reality was, it's not enough that you choosing one solution and thinking that is the best way to use this solution is that people will take in and use it. There is so many questions, so many ways to act with these technologies, so many ways for implementing these technologies that it's really not one size fits all. And that says that if you won't be sensitive enough for understanding the people, for understanding the organization needs, for understanding the technology solution, we won't be able to do things in the right way.
Thank you so much. Are there other questions from the students? Yes, Obioma. Obioma, you're mute. I'm sorry. Unmute yourself.
Okay, thank you, Professor. My question is this: since patient medical record is confidential to the patient and to the doctor, so what measures are in place to make sure there is no data breach and this electronic health records of the patients, taken from the data system, maybe by hackers? So what security measures are in place, to make sure that this doesn't happen? Thank you very much.
Thank you, Bioma. First of all, it's several kinds of ways to look at this. If you look at the side of secondary use of clinical data to carry out research on clinical data, if we want that the patient clinical data will be in this research and it will be with all the fields and everything, we must, it's called the opt-in mechanism. We must get the approval of the patients to bring this data to this to this research. If we want to make a big data research, it's a little bit more difficult because, you know, we want to make a high load research, and it's difficult to every person that is got his clinical data to get the opt-in mechanism work with this. And there is several ways if we want to enhance the more clinical researches and use better use for big data research. We try to find and suggest another mechanism. The other mechanism called opt-out. And the opt-out mechanism, it works only if you do several acute things to ensure that you anonymize this data. And it's not only to take the birth date or to take the name out. It's not anonymizing. It's supposed to be more complicated from this. It's working with special security tools. It's not easy like this, but it's not enough to work on the special technology tools, because, you know, everything that you taking out, someone else can find a way to take in, and you must be very good on what are the problems that's supposed to be happen. So it's not enough. So we have another committee that acting in this research on the field of to ensure that they can do this research at the organization. Only health organization doing those research in their own home, and they're not taking all the data and bringing out to the companies to do whatever they want. It's several kind of protective mechanism in order to protect this kind of data. This is the secondary use of clinical data. For the first use of clinical data, as I give you an example, what we're doing at ITAN. ITAN, it's the Health Information Exchange Network in Israel. When I go to hospital, the hospital doctor, ER doctor, can see my clinical data that is stored in the HMO. So this too, we're doing this in a secure way. It's a peer-to-peer network. It means that the doctor don't have all the data in his computer or in his hospital. Even in his hospital, the data stored at the HMOs, and you can see the data right in the time that I'm coming to the doctor, and right there you see the data. 30 minutes after you see the data disappeared from his computer. It's very important for the privacy.
You know, we have a course called Social and Ethical Issues of the Internet in the third year, where we deepen tremendously all the ethical aspects of the governance of new technologies. And if you add the word health to it, I guess it's an array of challenges that you have to face in governing this. That is quite amazing. I don't know if there are other questions from the floor.
There was a chat question.
What?
I see the chat question.
You see a chat question?
Yes. How telemedicine will work for the patient who need the psychotherapy treatment? We dove into this issue. Not me, the psychologists start acting in this field, and there are it's one of the psychologists is a good one that leading the field of psychology in the telemedicine community, always saying that telemedicine by video is not, it's not like doing clinical treatment by video. It's different approach, and it's really different approach. We must understand that there are things that we can achieve by those treatment, and things that they are not. But for example, for this psychotherapy issue, we saw that something interesting. Part of the doctors said that they work with children, and when they work with children look at the tablet or the iPhone of the parents, and and they act very, very natural, because they get regular to work with and play with the iPhone, and it helped them to open and to connect to the doctor in a better way that happened at the clinic. So this is one example. Of course, it's not good for all the cases, but we must understand, we now understand that even we promoting telemedicine, and we acting in telemedicine in much more percentage that we've done 2 years ago, we don't know enough in order to decide right at the beginning what is good or not good. We must practice more and try to find the ways that it's efficient, and there are some ways that it's not good enough.
Questions? Yes, Tommaso.
Hi, I'm Celani Tommaso from the third year of Global Governance, and I wanted to ask you, how long has it taken to create a sense of familiarity between the patients and this use of interface with the medicine? And also, how long do you think that this kind of system can be scaled up to bigger countries? Because I think also that getting the data and storing the data and using effectively the data becomes harder and harder as population grows.
What we're hearing from doctors, it's that the setup of telemedicine appointment, it's harder than the setup in the clinic. We must remember that in a regular way, the doctor in his clinic and the patient getting out, patient getting in, there are no technical issues. Instead of looking at the information system and look at the patient's history that's stored in the information system. And now you're adding more technological issues. Sometimes the patients don't hear you, don't understand you. There is connectivity problems, and it's really, really harder for the doctor to act in those fields. You talk about the time. I think we can't say there is one time that when we finish this year and the next year, the doctors will be feel comfortable enough with this issue. It's a learning. The approach that we're supposed to have is to make a learning healthcare system. And when you calling your healthcare system as a learning healthcare system, you call the doctors as a learning doctors, you can say that will be improvement in every aspect, but it's issue that we are entered in without really knowing if what's right for every single views and what not right for every single views. It's something that we need to be more practice on in order to decide whether it's good or bad for the doctor. What we need to do is to support those both patients and doctors. We're trying to do this in the community that we build. Some of the groups building programs for a practice program for the self. Some of the groups building to write some of kind of a textbook for those kind of professionals. We really need to support them because it's a new issue.
Are you okay, Tommaso, with the answer? Yes. Okay. I look at Assaf in my work at things that are close to challenge standards, the ones you mentioned. In Europe, we have something called innovative public procurement from that does not actually taking off as well as expected. They don't do it as much as in the US, they do it in Europe. And one of the things I wonder, with this challenge tender, you typically attract new firms that become larger and stronger because of working with you guys, right? Do you keep track of what happens to these firms after they have been won a challenge tender and started working with you, so as to measure the impact of your choices in terms of industrial policy and development of small firms? You have statistics on that that show that once they win a challenge tender, they become more resilient, more international, more able, or you don't do that? Because, for example, in the US, they have this huge small business administration program for procurement for small firms, but they don't keep track of what happens to them afterwards, after they have become suppliers for the public sector. They don't keep track of the performance, which I think is a waste. And you talked a lot about following impact of what you do, and I wondered if that's a dimension where you do that too.
At the beginning of the innovation, at our enter to the innovation issue, to finding startups to help the healthcare system, say for example, we thought that the right way to act is this field, the ecosystem wasn't good enough as we thought a few years ago. And we thought that the government's supposed to procure and to make this procurement easily for a new startup to enter and solve the healthcare issues. And we start thinking that we must do it by ourselves, to choose those companies, to choose one, two, three companies in some kind of areas, for example, the fall prevention, to make a collaboration between the companies and health organizations, especially here in fall prevention is the HMOs, and make the pilot happen in order that to learn from the pilot. And when we're looking at this now, the procurement issue is not, I think it's not the main barrier for fast delivery problems. I think that if we enable health organization to choose their own solution, the old technologies, and this is by incentives, I think it's a better way to enhance transformation. And we can get statistics from them either way. We don't need to do this by ourselves in order to get the statistics. So with the companies that we made tenders, they're now at pilot, the one that's supposed to finish a pilot, and he signed a contract with the HMO, and it's great. And we were very happy that a lot of elderly people enjoyed from this technology that we helped entering the HMOs. But still, if I need to think and to design it from the beginning, and that's what we're doing now, we're designing it again, I think the incentive program for health organizations is more efficient, because every organization find his own people to choose their own solutions that fit the organizations, the patient. And as far as you, and it's very, very important for us to be at the field that is close enough to the patients. So, for example, if a psychologist finds his own solution at his HMOs, he knows the patients better than me at the government. So it's very important that he will be the one who chooses the technology. Me, as from my eye of view, me and my section, my Ministry of Health, from our view, we can say if we can think it's good enough or not good enough, the effect good enough, the way to do this, and the way to achieve it's efficient or not. But I right now prefer the decentralized way to enhance technologies than the centralized way to find solutions, do it by myself. I don't think it's fast enough.
Wow, this is a big argument against the centralization. So you're basically saying that in this sector, there are very few economies of scale, to go back a little bit to Tommaso's point, but also that interoperability is not a big deal. I mean, if everybody can go on its own, is that what you're saying or not?
No, interoperability is a very, very big deal. It's but you as a government can say what is the standard that you want it to happen. You don't have to do it by yourself. It's not it's the same like other things that we spoke before. It's not one solution for all, and there is some barriers that if you won't do it by yourself, it's what won't gonna happen. For example, our health information exchange network that connecting clinical data from health organization, nobody will do this alone, because you need all this collaboration, all this cross-sectional work with different kind of health organizations. So this is one barrier that if the government won't act in this barrier, nothing will happen. If there is some problems in specific area that the market by itself or with incentive won't solve this problem, you need to act, you need to enter this field. But it's right for several things, and there are many things that it's not right. So what you need when you're deciding what is good for self-purchase and decentralized purchase is it depends of the problems that you want to solve.
Very interesting. Thank you so much. Any other questions on the floor before we let our guest go? Doesn't look like. Assaf, this was a very, very interesting moment for us to hear of developments that are advanced and at the same time, possibly, as Tommaso was saying, scalable. So we learned a lot. Obviously, the word governance for us was very much present in today, even though we didn't mention it very much, because all what you have said behind the scenes requires a huge amount of governance, I think. And you have basically illustrated it very well. Pamela, do I have to say anything else besides thanking our guest and the students, obviously?
No, again, to me as well, it was an opportunity to learn a lot. And what I want to keep saying is that I'm very happy that the University of Tor Vergata and the Israeli Embassy could set such a cycle of talks and workshops. I think it's a great opportunity for the students. If I think of myself as a student many years ago, now back, I have to go back many years. I think it's a great opportunity, and I hope that the students are enjoying what Israeli experts bring every week in this virtual room. And I think that this is kind of experience that we may reapply in the future. That's it. Really happy to see all of you here, Israeli experts, Italian experts, because Professor Piga is definitely an expert, and students.
And there's not only me, and there's other colleagues I've seen
from other departments, and students from Italy and other countries all together, listening, raising questions, and food for thoughts, let's say. So I'm happy for the time we spend together.
I'm happy to. Now we let them go. Assaf, thank you so much thank you, Valeria, for the organization. Thank you, Assaf, for this wonderful time. So it's time for you to put the microphone on if you want, and you can read the chat, Assaf, with all the students saying goodbye to you. Thank you.
It's a great honor to be here with your great courses and your great activity at the university. It's really a great thing. Thank you, Pamela.
Thanks to you, Assaf, a lot. Thank you.
Bye-bye, guys.
Take care.
Thank you so much. Bye, Professor.
Thank you. Bye-bye.
Thank you.
Thank you.
Have a great day.